the inherent nature of this lining is to grow every month because of the hormone stimulation and bleed at the end of it. And some of it, which is just on the lining of the pelvis inside there, it may not form a cyst, but the body is trying to clear that blood out. So commonest symptom people have with endometriosis is severe pelvic pain during the periods.
How common is endometriosis amongst women?
Comparatively, earlier Caucasian population was supposed to have more endometriosis and less in the African population. Now, unfortunately, the gold standard for actually saying whether somebody has endometriosis or not is still what we call it laparoscopy. We put in a telescope, we have a look and say, okay, fine, this is endometriosis. When I get a 25, 30-year-old lady who has got endometriosis, and if it is not a very large endometriotic cyst, and if it is only mild endometriosis, she's able to cope with medications.
Hello everybody, welcome to another podcast of Womanaari with Dr. Usha Kiran, and today we're going to be discussing a very tongue-twisted topic. It's called endometriosis. So I took a very long time to get the pronunciation right, but I'll tell you what, it's not just a fancy word. It's a genuine problem that's actually more common than we can think. I'll be honest, 2 weeks ago, one of my friends got treated for endometriosis, which is when I actually got to know that there's a problem like this. And then when I began to research, I realized how many people have it. So today we have our consultant gynecologist, Dr. Usha Kiran, who is also an endometriosis expert, who's going to be talking to us about all of these things. So welcome to the show, Dr. Usha. How are you doing today?
I'm good, thank you.
Okay, great. So doctor, tell us, what is endometriosis and how is it different from regular menstrual pain?
Okay. So the lining of the uterus, which is inside, grows every month and then it sheds during the period. Now this lining is supposed to be only inside the lining of the inside the uterus cavity. Sometimes, there are many theories, but this lining can be found either on the ovaries or inside in the pelvis outside of the uterus. Sometimes even in the scars of a cesarean section. Okay, rarely it's been found even in the nose. But the inherent nature of this lining is to grow every month because of the hormone stimulation and bleed at the end of it. So wherever it is, it continues to do its inherent thing. So let's say, for example, if somebody has it in the nose, which is a very, very rare condition, every period they can have bleeding from the nose as well. So similarly, in the pelvis, when they have it on the ovary or on the in the pelvic cavity, it bleeds every month. But unfortunate thing is the bleeding cannot come out. Like in the uterus, it comes out every month. It cannot come out of the pelvis. There is no outlet for it to come out. So this bleeding stays there and can give rise to a collection of blood on the ovary, which is called a chocolate cyst. It's called chocolate cyst because the old blood starts becoming darker brown as compared to the bright red blood. And this can continue to increase and cause big cysts in the ovaries, which can cause a lot of inflammation in the pelvis. And some of it, which is just on the lining of the pelvis inside there, it may not form a cyst, but the body is trying to clear that blood out, and it can cause a lot of inflammation. So in this process, it can make things get stuck, and adhesions and pain involved, sometimes even the nerve fibers. So the commonest symptom is pain. Okay. Now this pain and this endometriosis can also be in the muscle of the uterus as well, which we call it as adenomyosis, which can give rise to a lot. Again, that blood does not come out. So it stays there, and every time it bleeds, and then it's distending the muscle of the uterus, closed space. And then again scarring happens, so there's more pain. So commonest symptom people have with endometriosis is severe pelvic pain during the periods. Sometimes this pain gradually over a period of time can become throughout the cycle as well. It will start with just before the period, gets worse during the period and stays after the period, and then continues as a dull ache throughout the month. So commonest symptom is dysmenorrhea, we call it, severe dysmenorrhea, as compared to the mild, period pain people get. Which is tolerable most of the time, does not require medication, sometimes maybe a day of medication. That is normal menstrual period pain. If they're getting a lot of menstrual period pain, and especially the one which is starting before and continuing after the period for a few days, it's very typical of endometriosis.
Okay. And endometriosis is often actually called a silent struggle. Women take a lot of years to understand that this is a genuine problem. Why do you think this is so?
Because to start off with, the period pain has been accepted as something normal.
Very normal, yes.
Normal,
yes.
okay. So somebody has pain during the period, you say, oh yeah, that's normal. Okay, everybody around them, tells them that it's normal. And when we talk about period pains, or for that matter, any pain is perceived by each person very differently. So you might have menstrual pain which is slightly more than me. I might have slightly less. Somebody else might have, much more or much less. So when I say to you, I'm having a lot of period pain, you're like, I'm also having pain, but that's okay, that's normal. So you don't know the grade of pain that you're having, whether it is a normal period pain or is it actually something abnormal period pain, because there is no yardstick to measure the period pain, period pains. So so most of the women tend to think, oh, maybe my periods are a little more painful. But having said that, the awareness has changed now. People do realize, they know a little more about endometriosis. They know that the periods are not supposed to be too painful. So they do seek medical help now. Yeah.
How common is endometriosis amongst women?
Well, I can't really put down a figure as such because it varies in the population as well. Comparatively, earlier Caucasian population was supposed to have more endometriosis and less in the African population. But nowadays I see fibroids and endometriosis in almost every population. Okay, and especially because I am a fibroid and endometriosis expert, I get more number of patients. So I feel like every other patient I'm seeing is suffering with endometriosis. Like for example, yesterday I operated on 2 of them with endometriosis. Last week I probably operated about 4 or 5 patients on endometriosis. So it is a very common problem. And with the lifestyle which is changing, more obese women, more estrogen production, those conditions which are estrogen dependent are increasing as well. Plus pregnancy and more children would have kind of put a little bit of an interval for this endometriosis development. Nowadays we are all marrying very late, having children very late, having less number of children. So all that is also a contributory factor for more endometriosis.
Very relevant. Well, can you tell me a little bit more about some myths about endometriosis, that some common questions or things people come up to you with that you'd like to bust?
One of the things is that awareness is increased so much nowadays about endometriosis. Every other patient comes to me and asks me, do I have endometriosis?
Correct. Even when you don't have it. So you're expecting
sometimes over imagining the symptoms of endometriosis.
Yeah.
And it is such a difficult thing to tell somebody whether they have endometriosis or not. Common symptoms, as I said, is severe period pains, before period, after period, during period. If people are having difficult, painful intercourse, which is deep pain during intercourse, that is one of the common things. Sometimes people can have problems with passing stools as well if the endometriosis involves the bowel as well on behind the uterus. So if the symptoms are very clear cut, then we can say, yes, you probably have endometriosis. Now, unfortunately, the gold standard for actually saying whether somebody has endometriosis or not is still what we call it laparoscopy. We put in a telescope, we have a look and say, okay, fine, this is endometriosis. Yes, imaging techniques like ultrasound and MRI, we can detect cysts, and then we can say, oh, it looks more like endometriosis cyst. So far the gold standard has been laparoscopy. But recently, I think most of the viewers and most of the doctors are still not aware of it. There is a special test which has come. They can check from your saliva to see whether you have endometriosis or not.
My goodness.
The very, very recent one, okay? In the last couple of months it's come through. And it is available in Dubai. The only downside of it is that it is not covered by the insurance and it's an expensive test. But if somebody does not want to undergo laparoscopy to check if they have endometriosis or not, that is something that they can opt for.
Very interesting. And I mean, this question is coming to me quite, in my head, that, to what extent is period pain considered normal, and when should someone actually go consult a doctor?
Well, when I say normal, if you're not taking any painkillers.
Okay.
then it's normal.
Okay. Whatever your body can
Yeah,
tolerate.
and if it is not, so you're not taking painkillers but you're lying down in bed for the next 4 days, that's not normal.
Correct.
Just because you're not taking painkillers. If you're able to function normally, if you're going to work, you're able to concentrate on your work without worrying about the pain, without taking painkiller. Or if you take a painkiller for a day or so, one tablet, today and tomorrow, that is still okay. But if you have to take tablets round the clock during the periods, and if you cannot concentrate, on your work or on with the family or anything, then that's interfering with the pain, which is interfering with your routine lifestyle and work is not normal. It could be endometriosis, it could be something else, but it needs to be looked into.
Take me through the process of the endometriosis surgery. Okay, how long does it last? What are the risks involved after surgery? How long is the recovery period? Let's talk about that.
Okay, endometriosis surgery varies for different people. Okay, it's not just all endometriosis will be treated in one way. First of all, endometriosis, we don't generally advise surgery till a certain point. We want to treat them with medication. If the medication controls their symptoms, we want to keep them on medications. Reason being, when I get a 25, 30-year-old lady who has got endometriosis, and if it is not a very large endometriotic cyst, and if it is only mild endometriosis, she's able to cope with medications, I would rather not do surgery for her, although surgery might give her an immediate relief, because endometriosis is not a curable condition. With surgery, I cannot cure it completely. I can only cure it for the time being. So these women will continue to have new endometriosis developing with every cycle till they reach menopause. So if I do a surgery for somebody with the earliest of the endometriosis at 25, she will be coming back to me for more surgeries as the disease progresses again and again and again. So there's only so many surgeries you can do on people. So generally younger patients, I personally try to avoid doing endometriosis surgery if I can avoid it. If there's no large endometriotic cyst, it's only pelvic endometriosis. If we can manage their symptoms with medication, I would prefer to do so. However, if somebody is looking at pregnancy, fertility is their issue, then medications are not used, because most of the medications which are given, or almost every medication that's given for endometriosis, it acts as a contraceptive. It's hormonal. So while the patient is taking the medication, she cannot get pregnant. Once she stops the medication, the endometriosis starts coming back. So you're in a kind of stuck position. So for these patients who are looking at fertility as their main issue, then surgery is the best. We clear the endometriosis for the temporarily for the time being. Then the pelvis is clean enough for them to get pregnant if everything else is okay. And that will give us that window period to get pregnant. So patients who are not responding to medications with the pain of endometriosis, or patients who are looking for fertility, those are the ones we are looking at surgery.
Okay.
In surgery, again, if it's only an endometriotic cyst, we remove the cyst, leave the ovary. If it is endometriosis in the uterine wall, which is called adenomyosis, we remove the adenomyosis and stitch the uterus up. If it is endometriosis which is actually sitting on the bowel, we'll have to remove the nodule and dissect it off. If it's somebody who has finished childbearing, who is 40 plus or 45, who has been trying medication, not getting better, for them do a full clearance of removing the uterus and fallopian tubes and the ovaries and everything, a total clearance of endometriosis is what we do. So based on the symptomatology, based on the findings that we have on ultrasound, based on the patient's age, patient's wishes, patient's childbearing, all these are the factors which we consider to do surgery or not to do surgery, or to do which type of surgery.
Interesting. What's the recovery period like?
So again, depending on the surgery, most of these surgeries, either we do a ovarian cystectomy or adenomyomectomy or a removal of the uterus. 2 days stay in the hospital. We tend to do them laparoscopically. They are difficult cases to do laparoscopically majority of the times, because everything is like completely stuck.
Correct.
A little riskier because it's stuck to structures like your bowel or kidney tubes or bladder. But I do them laparoscopically. 99% of the time we manage to do them laparoscopically. So the recovery period is like 2 days stay in the hospital, 2 weeks off from work for any laparoscopic surgery. That's a standard kind of, we look at it as. Depending upon the amount of dissection we have done, somebody might take a little longer, somebody might take a little lesser. Sometimes it's so difficult that we won't be able to complete it laparoscopically. We might have to end up giving a bigger cut to do that. Sometimes injury to the bowel or something can happen. If the endometriosis is so much going into the bowel, we might have to resect the bowel as well. So those cases also will require a little longer recovery.
Okay, interesting. And is endometriosis common in married women or unmarried women?
Again, married and unmarried does not matter.
Right.
It is more to do with the estrogen dominant women. And also, if you've had more children, your chance of endometriosis is probably lesser as compared to if you haven't had children.
Okay, very interesting.
But it's mainly the genetic predisposition.
Okay. And imagine there's a lady who's in her 20s and she's trying to conceive and she's having difficulties. Is just pain during intercourse one of the symptoms that she should be aware of? Or there's anything else also that she should be aware of in order to think that, okay, this could be endometriosis?
Period pains and pain during intercourse are two common symptoms.
Okay, so just that's...
And they also can get a lot of people with long-standing endometriosis because there's a lot of inflammation going on. They feel very exhausted, they feel bloated. Those are very vague symptoms, but they can be endometriosis as well.
Correct. So in terms of the treatments, we are looking at medication and surgery. These are the two common ones.
Yeah.
And of course, like you said, that even surgery is not like an ultimate thing that, it'll just get over and you may not get it. What is the probability of someone who's gotten endometriosis, has had a surgery, and them getting it back again?
It is very variable. So you can have somebody who's had a surgery and then they don't get any endometriosis for the next 2 years, 4 years, 5 years. Okay, very lucky.
Yeah.
Or somebody who has had surgery who can come back in 2 months with a cyst in the ovary, which is very disheartening. So what we tend to do is, majority of these patients, you do the surgery, you always put them on medication immediately after the surgery to prevent the recurrence. Now, if they're planning to conceive, then we say, okay, go ahead and conceive. No need for medication. Otherwise, if you're not planning to conceive, stay on the medication so that your chance of coming back with another cyst is less. There are various medications used depending upon the situation and the time period that we're looking at. But for all my endometriosis patients, I always put them on the medication to prevent the recurrence after that.
Okay, interesting. And can lifestyle changes, diet, exercises make a difference in managing endometriosis?
Yes, to some extent. If you, as I said, all estrogen dominant conditions can increase if you have more fat in the body because fat produces estrogens. So keeping your weight down, exercising, eating a healthy diet, more vegetarian, more Mediterranean diet might actually help. But we don't know to what extent because there are a lot of women who are obese and they don't have endometriosis.
Correct.
There are a lot of thin women who have endometriosis. So, but yes, if you have endometriosis, keeping your weight down not only helps you endometriosis, but it will help you in all other ways as well.
I think in all our conversations, one of the underlying, recommendations has been weight control and stuff.
So weight control can decrease a lot of problems in women. Endometriosis, fibroids, polycystic ovaries, bleeding irregularities, fertility issues. They all can be weight related as well, and weight can make it better or worse depending upon.
So this is a very personal question and you can choose not to answer it, but how do you maintain yourself despite being so busy? You're at you're obviously experienced, you're looking good, you're healthy. What do you do to take care of yourself?
Okay, diet and exercise is the only thing, and I always have believed that diet actually takes a bigger proportion towards contribution to health rather than...
so you don't take any sugar, you don't take any dairy?
No, I take all that. So it is not just avoiding everything, it is having it in moderation. So I have been, let's say now, I before I got my children, I never used to cut the carbs. I come from South India and lots of carbs and rice in the thing. But then I started gaining weight. So I decided to cut the carbs. Fat has never been a major issue because from childhood at home, the cooking was done with very minimal oil. So I'm used to that. And fried food, sweets, all that was not a habit. So it's generally, I'm not like craving for sweets and all that. But I have sugar in my coffee.
Right.
So I changed over to sweetener later, but I don't mind having sugar in my coffee. I drink only 2 or 3 cups of coffee, so I don't think it makes a difference. I still eat rice a little bit. I still eat fried food if I want to once in a while. But overall, less oil, less carbs. I wouldn't say more protein. I would like to, but that doesn't happen so much. I eat a lot of grains. That's very important. But having said that, recently, now that you've asked this question, I want to tell my viewers this. Recently, I actually gained I've always been maintaining my weight and, a little bit of here and there. I exercise quite a lot, climbing mountains and trekking and all that. But recently, I gained, maybe the exercise went down, maybe the diet was, a little bit here and there. But my weight went up, maybe my thyroid issue, I have no idea. Some metabolic issue because it was something abnormal. It went up by 4 or 5 kilos.
My goodness, okay.
Okay. And I'm like, this is not me.
Correct.
Like, I'm feeling like everything bulging everywhere kind of a feeling.
Yes.
So, and then I said, okay, fine, let me do this, let me do that. I mean, nothing was kind of budging and it felt like this is some kind of a metabolic kind of issue. And then on top of that, my sugars have always been normal, although I have a family history of diabetes. And my cholesterol, which has always been normal, shot up as well. And I said, hang on a minute, this is not normal. So something is going wrong and I need to get this weight down. So I actually went and took Monjaro to reduce the weight, apart from the diet and the exercise that I'm doing, because this time I felt I'm not able to do it just with what I'm doing normally. I don't know whether it is I'm 60 now, whether it is the late menopause kicking in, effect of the menopause after 10 years kicking in. I don't know what it is. But yes, and I cut down all the oil in my food, just temporarily. We are experts in making no oil food at home now. Make even chicken butter masala without butter and oil. So yes, it is difficult. As you age, it gets even tougher. Sometimes, yes, with a little bit of medical help, it makes a difference, I suppose.
I agree 100%. We'll discuss Monjaro another time because now with what you said is actually, I mean, we'll digress. We'll get into Monjaro. We'll come back to endometriosis. But thank you so much for sharing, what you've been doing. Well, doctor, now let's talk about, this is my final question for today, and that is, there's this fear around fertility, especially when someone has endometriosis. Is it that once a person has endometriosis, they cannot conceive naturally?
No, not necessarily. People with endometriosis, I've seen them conceiving as well. It depends on how much damage the endometriosis has done to your pelvis and your fallopian tubes. Okay. Now, in some people, they can just have a small endometriotic cyst which is there for a long time, and it doesn't really cause much inflammation. Some people can have small cysts, but a lot of inflammation in the pelvis. So it is so variable. You can't tell patients that, just because you have endometriosis, you don't conceive. So I generally tell the patients, you have endometriosis. If you want to try conception, try. If it happens on its own, fantastic. If it doesn't, then be prepared, because endometriosis is a main factor in infertility cases. So if it is affecting your fertility, yes, we need to treat it. But a lot of patients have problems with endometriosis and fertility rather than not having it. The ones who don't have problems with fertility are the exceptions. So when people have endometriosis at an earlier age, I tell them, if possible, don't delay your pregnancy plans, because as the endometriosis keeps on causing more and more inflammation, it compromises your fertility as well. So if you don't have any other reasons for not postponing pregnancy, don't postpone it.
Very interesting, doctor. Thank you so much for your time. We've had a wonderful discussion on endometriosis. For everybody who's listening to us, if at all you have excessive period pain, etc., do get it checked. It is more common than what we can imagine in today's date. And yes, if at all you have it, don't delay pregnancy. And before anything, don't forget to follow us on our Instagram and our YouTube channels. That's Womanaari on Instagram and on YouTube. We'll be back soon with another topic. This time we're going to talk about Monjaro and how has it affected Dr. Usha. Is it recommended or not? In the next episode, let's catch up soon. Thank you so much. Thank you so much, Dr. Usha. Thank you.